Good afternoon, everyone. I apologize from behalf of Dr. Rashesh Pothiwala that he could not come because of his personal reason. I am privileged to get this opportunity to present about approach to patient with intermediate coronary stenosis, a constant dilemma of cardiologist. As we know, as a cardiologist, we get frequently we face the problem with the intermediate lesion in our cath labs, and we get the dilemma like in this slide that I showed, that the glass is half full or the glass is half empty. Every cardiologist, in every sense, they can feel they should stent it or not, and there is a intra-person variability also. Another cardiologist feel the same problem. So how we manage this condition, I will discuss in my presentation. So this is a case, 86-year-old male. He presented with complaint of chest pain. He has a limited physical activity because of bilateral osteoarthritis. He has stented LAD 2013. So this was basically RCA, which was having the sluggish flow and the critical lesion in proximal part. So he was stented and got the complete revascularization of RCA. But in case of LAD, we can see there is a intermediate lesion. Is it looking like a 60-70% lesion? As a cardiologist, it is a very big dilemma. If you treat continuously these patients, you will be labeled as a hunter, like you stent every patient. But if you leave these cases, you will be considered as like you are useless. You are not attending the critical lesions. You are leaving them. So we should know the objective parameters to treat that, which lesion should be treated and which should not be treated. So how can we define that? First of all, I will just discuss the limitation of coronary angiography. Angiography is basically 2D lumenogram, because it gives us a lumen, the contrast in the lumen. So we try to make it 3D mapping by taking the multiple shoots and rule out that and assess the anatomy of the coronary artery. But sometime in intermediate lesion, it is very difficult to define that. Despite of multiple attempts and multiple use, we are not able to define that it is a treatable or not treatable, or we should leave that lesion. So my next question is, stenosis and ischemia are the same? Kya Gangadhar hi Shaktiman hai? But my answer, unfortunately, is no. Stenosis and ischemia are a different thing. In an intermediate lesion, just think of it. If intermediate, our main goal of revascularization is to relieve the ischemia and improve the blood flow. But if stenosis is not inducing the ischemia and we revascularize that lesion, that is not going to help the patient. So revascularization is not going to benefit the patient. In that case, we cannot rely on the coronary angiogram. So in this case, the physiological assessment of lesion comes into picture. So to treat the ischemia, not the lesion. So this is the literature which is suggesting that ischemia and stenosis are different things. This is the study which showed that there is a huge discrepancy between the stenosis and ischemia. We can see the coronary, sometimes we see the coronary angiogram is showing the critical stenosis, but they do not have the critical ischemia. And there is a study of 4,421 patients in which the revascularization, 71% patient revascularization was planned on the basis of coronary angiography. But when FFR was performed, it is seen 38% cases we were doing the right angioplasty, right revascularization, but 34% cases we were wrong. So this is the difference between the physiological assessment and only looking at the anatomy by the coronary angiogram. So what is the significance of that thing? There is one more literature is there. So if there is a 70% of lesion, and now this two lesions which are 70%, one is having the ischemia, there is a significant ischemia by lesion, and second showing no ischemia by lesion. In that case, patient with 70% of lesion and ischemia, risk of death or myocardial infarction in next 5 years is 20 times higher than patient who has the no ischemia. So physiological assessment is important. In this case, I will just discuss that fractional flow reserve. These all they are coming in next few slides. Exposes the functional aspect of the stenosis and affected by the following parameters: epicardial coronary artery anatomy, extent of perfusion territory, microvascular function, and myocardial blood flow, including the collateral. So anatomic severity of stenosis is just one component of physiological assessment of coronary artery. So as I discussed that angiography alone is not sufficient. So which are the another tool which will help us to assess the patient and treat the intermediate the lesion. So there is a one component is the physiological tools, and second imaging, which we discuss after discussing the physiological tools. So first there is a hyperemic FFR, fractional flow reserve. Basically the blood flow, we know the physics concept that flow is equal to pressure into resistance. In FFR, we try to minimize resistance. Hyperemic, we give the drugs which maximize the vasodilatation, like adenosine, ragnanosine, and papaverine previously used. So we try to minimize the resistance of coronary artery across the lesion. Then we pass a wire across the lesion, and distal to wire and proximal to wire, we assess the pressure. So that pressure, as resistance is minimal and the equal in both lesions, so pressure will be directly proportional to flow. So the pressure in distal to the lesion part and proximal to lesion part will give us the fractional flow reserve, the flow in the coronary artery. So FFR functional information takes into account the size of the perfusion territory, viability of the supplied myocardium, absence of prohibitory microvascular disease, and collateral flow function. Routinely using the FFR reduce the MACE events by the 28% and improve the outcome and doesn't prolong the procedure time. IFR is the newer concept which is used. So in FFR, we are using the hyperemic substance like adenosine and in these drugs. So they maximize the vasodilatation and minimize the resistance. In case of FFR, it is an instantaneous wave-free ratio, which is measuring the flow, coronary flow in the cardiac cycle, 75% of diastole, when there is a minimal resistance. So IFR is calculated by that. Now it is recommended that FFR and IFR are almost equivalent, and they are recommended as a first a recommendation for the physiological assessment. RFR is used in the the nuclear scanning during the stress. So FFR, what is the incremental value of FFR in intermediate lesion? That is the question. I will give you one defer study. Defer study was basically patients were taken. There were two groups. When FFR value is more than 0.75. So these are basically FFR value more than 0.75 is suggestive of there is no significant ischemia. In these patients, the two groups were taken. The lesion was intermediate. So two groups were taken. One in angioplasty was deferred and one in which angioplasty was performed. So we can see the results. These are the 5-year data, but even after now 15-year data has been published, which showed that in which the angioplasty vascularization was deferred, they had the less chances of cardiac death and acute MI comparing to whom the angioplasty was performed. So this is the importance of assessing the ischemia. So as we discussed, if there is no ischemia, FFR is more than 0.75, we should not perform the angioplasty, coronary angioplasty. So now second thing, does FFR make a difference in decision making in stable angina? Stable angina, as you know, that ischemia trial has come in recent years. The ischemia trial shows that coronary angiogram, we do the coronary angiogram, and if there is a stable angina, medical management is equal to the coronary vascularization. But FAME2 trial suggests that if we assess the ischemia, like if we do the FFR of target lesion, and if FFR is less than 0.8, we do the PCI plus medical treatment versus medical treatment. The PCI plus medical treatment is far superior comparative to only medical treatment. So this is one of the thing that stenosis is not synonymous of ischemia. This trial and ischemia trial are the example of that theory. But FFR, there is a limitations of FFR also. It doesn't give any information for anatomy and the morphology of lesion, only measure the pressure drop, not flow. Although we try minimize the resistance between the lesions, but still there can be some resistance also. Technical challenges, drifting, waging, calibration, equalization, these all the technical problems which we face during the FFR, so results are not so frequent to produce the good results. And unreliability, the ACS and the serial lesion, it has still problem, and it is little help in the procedure planning and the post PCI stent optimization. So these limitations can be overcome by imaging, IVUS and OCT. So these lesions, precisely quantification of disease extent and severity, it helps us to assess the plaque characteristic, assess the vessel wall, and accurate sizing of vessel. So these intravascular imaging are helpful to overcome the limitations of FFR or physiological imaging. So this is very important lines, that physiology tells us what to treat and what not to treat, but imaging help us how best to treat. So they assess the morphology of lesion, optimal stent optimization, and are they going to predict the physiology or not? That I will discuss in fewer next slide. So since 1999, there is a study of the study between the FFR and the MLA, minimal luminal area. Are they specific, and sensitivity and specificity are equal or that? So last 25 years, it has seen that if left main coronary artery, there is a MLA less than 0.5 to 6, then they are equal to FFR value of less than 0.75. So they are having the inducible ischemia. And in case of non-LMCA lesion, if MLA is less than 0.37, the FFR value is best predictor of 0.8. So, so now the OCT is also having the same concept, but their value of MLA is comparatively low. So FROZA trial and INSIGHT trial are newer for FFR. A comparison of FFR and OCT MLA. But MLA has some problems. There is a fallacies of MLA based FFR prediction, because it is difficult to define that MLA cutoff of MLCA and non-MLCA. Better correlation in MLCA than non-MLCA stenosis, owing the limited variability of MLCA length, diameter, and amount of supplied myocardium. So now their concept has come, the OCT derived FFR and the IVUS derived FFR, they are basically based on the basic fluid dynamic equation, and by that they are measuring FFR. Still it is not useful in practical purpose, but this concept has arrived in cardiology. Other than these imaging parameters, non-invasively we can do the CT coronary derived FFR also. This is the similar to the FFR invasively. The CT FFR, if value is less than 0.75, we have to consider the invasive angiography. It is more than 0.8, so we do not need additional testing. But if it is in gray zone, then we have to assess the patient condition. So there is one more concept of quantitative flow ratio. It is in angiography itself. What we do, we take the two angiographic projection at the angle more than 25 degree and monoplane or biplane. So there is a software comes which measure the flow rate and calculate using the combination of contrast bolus from the frame and count the 3D QCA. So this is also a new concept. So my conclusion is that PCI in intermediate lesions should not perform the basis of coronary angiography only, because ischemia is very important. Without demonstration of ischemia, intermediate lesions should not be revascularized. IFR and FFR are recommended to assess the hemodynamic relevance of this lesion, and there is no competition between the FFR physiological assessment and the anatomical assessment by IVUS OCT. They are basically complementary to each other to treat the intermediate severity of lesion. So this is our Sterling Hospital, Ahmedabad, where we did the first impella of Gujarat. We did the orbital atherectomy also. So thank you so much for giving me this opportunity to present this topic. Thank you.